I was just curious about the group's feelings on this in relation to TPA for stroke. Do people have more confidence in this being a legitimate positive thing for stroke versus TPA?
Yes.
I have a suspicion that they do. The evidence seems to be much clearer here, but I'm just curious.
Overwhelmingly. I mean, I think it's overwhelmingly more favorable. The 3 trials in 2013, there's no perfusion imaging to go along with it, so automatically, intuitively you expect to have worse outcomes if nobody on the front end before intervention has said there's some hope of retrieval brain tissue here. Supposedly, and I don't know anything about the devices, but supposedly the second generation of those devices were better. But I mean, I do think the data, especially the most recent data, is overwhelmingly favorable.
It's likely that TPA probably does work in a small subset of patients, but it's been used in a shotgun approach with very poor outcomes as a result. And I think that's basically what you're saying. Correct me if I'm wrong, but you're saying that this EVT is probably in a similar position as TPA. It's probably useful, but only in very select patient population.
Yeah,
and there's a huge, it's probably going to be, except for the same fate that TPA did, unfortunately, as far as being utilized way outside.
Yeah, the danger is obviously indication creep. Jim brought that up. Unfortunately, like I said at the very beginning, standard of care, if you're eligible, has largely become IV TPA for stroke. It's kind of here to stay. If it was me, I would want catheter-directed thrombolysis with TPA or clot retrieval. If they could do it without giving me IV TPA beforehand, I think prefer that.
Difficulty and the skill level that it takes to perform this is going to prevent it from having the type of creep that IVTPA, because anybody can give IVTPA really, but there's always going to be significant limitations as to who can do this.
And that's kind of to Jen's point about cost. Neurointerventionalists, it's usually most of the guys are neurologists, followed by fellowship stroke neurologist, followed by an interventional 2-year fellowship to be a stroke interventionalist. So it's like 8 years of training to be one of these guys. They're going to be hard to hire. They're only going to be in specific centers. You're putting together a team basically to support these guys for what most of your folks will say is only going to be a handful of cases in a month. So you're talking about a place like us maybe having a few dozen cases by how selective they were in these trials being eligible for endovascular therapy. So I mean, the cost really is significant. I mean, it's a legitimate critique.
So it's not going to ever have the potential for the same indication creep that, and I say this to criticize one thing, as say cath is. And we talk about how great cath is in STEMI, but the reality is it's gone way outside of STEMI. And I think it's well recognized by everybody, including CMS, that ridiculously millions and millions and numbers of caths are done every year that shouldn't be done. So,
but there's still the possibility of significant creep at the institutions where this is going to be available, because the hospitals have invested huge amounts of resources to hire the appropriate personnel, to buy the expensive equipment. And the reason, let's be honest, the reason that, at least in some large part, the reason that those resources have been expended is because it's a huge money winner for the hospital. If the hospitals referred a lot of stroke patients, they're not doing this because they're losing money on the procedure.
And you'll never be able to rely on the administration of the hospital to govern it, because they are the ones making money. It's always going to be up to the federal government or CMS, so some offshoot of the federal government, who, based on what we've seen over the history of the federal government, they're going to screw it up.
The obvious next step is to start CTAing like TIA folks and stuff like that, seeing where there's potentially a lesion that we're just waiting for some kind of a drug-eluting stent that can then stent their stenotic MCA that's not really infarcting and stuff. That's the obvious next industry step, is to find that perfect stent that we can start CTAing folks for and putting electively a stent into.
That's coming in, and like y'all said, I think the estimate of 60,000 strokes a year that could benefit from this is way too far. Some of these studies,
the PI of one of the trials.
Yeah, a little bit biased. Some of the studies showed that they probably rejected about 98% of ischemic strokes from getting this procedure. So the odds that this is going to be the new thing that fixes strokes are really low, and that the risk of a bunch of yahoos that don't get the number of reps that they need trying to do this very tough procedure, because you're looking at like the superstars. These were the most elite stroke catheter folks in the world doing these trials, and they were positive in 2015, but a lot of those same folks couldn't get the old devices to work. So the odds that just random guy hanging out at some even large shop is going to be able to get the number of cases, very doubtful. But I think the administrative pressure to say, oh, look, we just spent $500,000 building you a new suite to do this in, you better use it. I mean, and so the creep is going to happen where it's not just big proximal MCAs that I think the data overwhelmingly shows there's a benefit to. It's going to be smaller and smaller strokes that are more and more close to 12 hours. It's going to have the potential for a real disaster.
One of the things that we got to keep in mind is these patients, they need to have their intervention within a set time frame. So like our team here, they will not do the procedure unless they are sticking the knee, they're poking the groin by 5 hours. So that kind of only adds another 2 hours to the window we already have established, or half hour if you look at the extended window. So one of the things I've kind of made my mission is trying to educate the EMS folks on whom they need to bring to the comprehensive stroke center. So like these little small wake-up strokes with a little bit of numbness, they can go to any primary stroke center, but the ones like you mentioned, like your father with a dense hemiparesis and a fixed gaze, I'm trying to educate them that they need to send them to the comprehensive stroke center to begin with. Trying to educate the people to take them to the right place at the right time for the right intervention is key, I think, in this point.
So EMS, they see this huge hemiparesis. Instead of just trying to drive them, which could take 2 hours from some of these places, just call them.
It depends on where they're located. Just like trauma, sometimes it's not worth flying somebody, even though it seems like it's faster, but you got the spin up time, the cool down time, loading them up, all that kind of stuff that ends up they get taken by ground faster. But I have bigger influence in some of the EMS agencies than I do others, and some of them still give a lot of pushback as far as wanting to bring patients to us. They'd rather take them to another facility, which then unnecessary transfers needed later on, and then there's a delay in care and they never get their procedure. So I think the big thing is kind of that influence, trying to take them to the right place the first time.
So I think a lot of great discussion. I think it's going to develop more and more. For those of you that are moonlighting or that are looking at jobs, make sure that you know what your shop does, because this is something that you don't want to figure out at 2 a.m. of how do I transfer and where do I send them to, and are they doing that at this shop, or are they just treating it locally with IVTPA? You need to have a plan for this, because I guarantee you don't want to try to figure this out when the patient hits the door and the time is really dependent. You want to ask this question at your faculty meeting to figure out, hey, what are we doing with our large proximal MCA strokes? Are we trying to package these folks? And if so, how do we actually execute that?